we'll go on with, oh, we didn't record, okay. So back to you, Amanda, for the next aliquot.
The past medical history, the patient don't have any past medical history and use acetaminophen. So the patient recent complete 1 week of amoxicillin for a dental infection in his bottom right molars prior to his symptoms starting, denies tobacco, drugs, and is a social drinker.
What do you think, Ibrahim?
Yeah, so I think that they had the dental infection prior to their presentation probably is an alarming feature of history, that they could have probably had some kind of ascending infection to their brain. I think this would most likely necessitate workup for them, so CT could probably be necessary in this case. But also, I think another interesting point is regarding the acetaminophen and its relation to headache. So when they probably developed a headache, I'd assume that they took in some acetaminophen. So Amanda, do you have some kind of information if it resolved with that acetaminophen, or did it still persist with it?
Still persist.
Okay, so Ravi, what do you think about it?
Yeah, it's interesting, these two pieces of information. Number one, the acetaminophen, you have to explore the possibility of could this cause something in the head itself. Side effects is something sometimes we skew over and we don't entertain as a possible contributor, or is it a distractor? But I think you actually focused in on a very important point. If the acetaminophen resolved the pain, then this could be inflammatory, of the inflammatory nature or variety. But the pain didn't resolve. I know from people that have had dental infections, acetaminophen can be very relieving of pain, so it can be helpful in that case. And then the amoxicillin, you have to sort of like deja vu. This came up in last week's case, and people were talking about liver inflammation due to amoxicillin. You could have maybe a drug-induced like hypersensitivity reaction. There's no rash or other features. So amoxicillin can cause a variety of different infections. Complications, but this doesn't seem to be something that that would be caused by amoxicillin. So we definitely have to run through these, do a check to make sure these aren't the contributors. And I think denies tobacco, drug use, social tobacco, as we all know, epidemiologically, the age range doesn't fit, but tobacco can result in all sorts of oral malignancies or contribute to oral malignancies. So something we also have to think about. So at this point, this dental infection, as you clearly had stated, Ibrahim, is very, very good connection, connecting the dots here that this infection can migrate up into the cranial fossa. So various places through the nose, through the cribriform plate, through the dental nerves and structures, the vessels, you can get thrombosis, and then they can actually lead to intracranial processes, brain abscesses, and so on. So something to think about. And right now we don't have any signal for infection, but I'm very eagerly awaiting the temperature, white count as well, and differential to see if we are going to have to focus in through the lens of, or shine our lens on infection versus inflammation versus all the other systems that we talked about. Back to you, Amanda.
Great discussion. The vital signs. His temperature was 37.4 Celsius. Heart rate is 74 ppm. Blood pressure was 111/48. Respiratory rate is 20 ppm and SATs 98% on room air. Alert oriented and is no acute stress. In small lingual ulcer that measure 0.5 just left to the midline at the distal aspect of the tongue. Pulmonary, abdominal, and cardiovascular normal. Skin pale, but without rash, petechias, purpura. No focal deficits, and cranial nerves intact, no weakness, oriented in person, time, place. I can give you some labs.
I think I love this physical exam. There are a couple of thoughts that are flowing through my mind, but Ibrahim, you want to take a stab at it? I think it's a great exam, and it kind of helps move the needle to another couple of the hypotheses that we had generated earlier.
Right. So I think that considering that the patient is afebrile, I'm starting to sway away a little bit from infection, but then on the throat examination, it seems that they still have this unresolved lingual ulcer. So it could be that they had treatment failure with amoxicillin that they were prescribed. But then also with the temperature, touching back again on it. But I feel at this point, we should most likely not rule out infection just yet. And we should probably think about inflammatory causes that this patient could be presenting with apart from the infection. But I'd love to hear more from you, Ravi.
Sure. Yeah, great thoughts there. I just love that in discussing with you, you're starting us down the road of possibilities. And just to add to the great thoughts that you had there, yeah, you picked up exactly on this ulcer. Is very interesting, right? We start thinking about all sorts of different systemic diseases that may have associated ulcers, but here I think just one small ulcer. And is it truly an infectious ulcer? I don't think so. With the course of amoxicillin, it's non-resolving, but I am trying to connect the dots here to see if this ulcer is associated with what has been presented in the first aliquot. But is this a systemic process? So do we need to rummage through all the possible autoimmune disorders that have associated lingual ulcers? I don't think it's kind of early at the stage. I wouldn't really start thinking about some of the processes like Behçet's and so on. Then going back to our thought of dental infection, is it connected to that? So when you look at lingual ulcer, I remember, yes, you have infectious associated, so bacterial, viral phenomena. Could this be traumatic? It could be a very common cause. Somebody bites their tongue and then develops this ulcer. Other causes, I'm thinking you have the autoimmune phenomena. And then we had a thought of possible malignancies. And here again, I don't think we have to go down the branch point of malignancies in this case. So there's no tobacco use, there's no alcohol, social drinker, but heavy alcohol use or chewing tobacco. Those could lend or portend to malignancy development within the oral cavity.
Right. Yes.
So
I agree. Yes.
Yeah. So at this point, the infectious variety is what I'm kind of concerned with. And let's see with the labs. Any other thoughts, Ibrahim, before we move on to the labs?
Yeah, really just about the pale skin. I think it could probably clue us to some kind of pancytopenia or anemia. So I'm just waiting for the labs. Yeah. So Amanda.
Oh, actually, before that, yeah, I was moving along through this whole lingual ulcer process, but yeah, you actually hit on a very important point there. Look at the blood pressure. You see this diastolic, very low diastolic number there, and what we usually call that is a wide pulse pressure, and it's very fascinating in clinical reasoning. We're always looking or grabbing for any bits of data that could help us clue in on the diagnosis, and I think this really is important. If we entertain that or put that together with your finding of pale skin there. I think anemia, yeah, it could be part of pancytopenia. You're absolutely right. And the data will help us with the labs. But this definitely, to me, it means we could be dealing with anemia here and significant anemia. There are obviously other causes that we have to think about, like valvulopathies, but pale skin and wide pulse pressure, I'm deeply concerned about anemia. And how can we involve or start putting anemia with this? Thinking about the dizziness and weakness you had mentioned right at the get-go. You were thinking about pre-syncope, anemia can be a contributor to that. So that's great. We're building a scaffolding here, and now we're at the juncture where I think anemia is probably highlighted and is front and center of this problem here. So we'll see what the lab show to see if the anemia is the problem. Are we dealing with a bone marrow problem? Are we dealing with a peripheral process like hemolysis, or a loss of blood like hemorrhage? It could be within the body, or it could be outside the body as well. So back to you, Amanda.
It's incredible how with the physical exam how will the lab come? Incredible. So the WBC 2K, low neutrophil count, hemoglobin 3.9, hematocrit 11%, platelets 28. Okay, reticulocyte count 29, MCV 109, RDW 18%, and 0 histiocytes, anisocytosis, poilocytosis, hard teardrop cells, and hard hamlet cells.
Anything on the chemistry before we start dissecting this?
No, I have the chemistry. I will give you. Sodium 138, potassium 4, fluoride 107, glucose 99, BUN 8, and creatinine 0.8. I have a LDH too, is 245.
Very interesting. You want to take a stab at it, Ibrahim?
Yeah, so actually when I first thought about pancytopenia, I started thinking about some kind of myeloproliferative disorder. But then I think it became really interesting when the retics were 29. But this patient seems to have a very low hemoglobin. So this is definitely not some kind of iron deficiency anemia. And then I think this is probably confirmed much more that it's not microcytic anemia. So I think this is a macrocytic anemia, but then when you think about macrocytic anemia, I know that we usually thought about folate as well as vitamin B12 deficiencies, but then this is not an elderly patient. Most likely, they are not really, they're not really on a strict vegan diet. At least I haven't heard of this until now. So that's also interesting for me. Another point as well within their hematological profile that's interesting is the rare teardrop cells, as well as the slight anisocytosis. And then I think this touches back on the point that they might have some kind of bone marrow issue, some kind of myelofibrosis, and also liver disease. So I think you brought up early in the session that they might have some kind of idiosyncratic injury due to their amoxicillin use. So I think that's really interesting, but I'd love to hear more about your thoughts.
Yeah, so the data is, we can actually work with this data any of possibly 10 different ways. And I do really like that usually we sort of gravitate towards MCV and then try and use what we've learned with macrocytic anemias. And you've named like 2 causes that we usually teach, but then we have to start thinking of or think about this in the context of this pancytopenia that is at play here. So I think I would actually look at this through the causes of pancytopenia. And if you go to the CPS website, they have a great workthrough of pancytopenia. So you mentioned the bone marrow being one of the possible causes. So bone marrow failure, and we see here the reticulocyte counts are elevated. So when we go down the branch point in the workup of anemia, if the retic count's low, then there is probably a building block issue, and then we have to go through the normocytic, macrocytic, microcytic. And this isn't foolproof. This doesn't always work all the time because the retic counts may not be exact. And again, you have to calculate a reticulocyte index to actually work through this framework. If you have a elevated reticulocyte index, in that case, then there may be the bone marrow is responding to maybe blood loss, maybe sequestration, maybe also a hemolytic process. And here we do have LDH is elevated, but LDH doesn't necessarily mean that there is a hemolytic process at play here. So with the haptoglobin being normal, I don't think we need to go down the route of hemolytic anemias as a process. So what are the other causes of pancytopenia? So we have to think about marrow infiltration. So early we had talked about possibilities of malignancies, and then other causes where there'll be marrow infiltration due to non-malignant causes like sarcoidosis or granulomatous disease. And usually the smear here is interesting. We do have anisocytosis, some teardrop cells, some helmet cells. So I'm going to focus in on teardrop cells. And I think you do usually see with marrow infiltration teardrop cells. And I'm going to sort of use, I got sort of biased towards myelodysplastic disorders. On a bone marrow smear, you would see a hypercellular process. And you do see macrocytic anemia in that case. So MDS is one of the causes of marrow infiltration and pancytopenia. One, you also mentioned myelofibrosis. And again, on that, it will be a dry tap. So the bone marrow will show absolutely no evidence of progenitor cells, and there'll be a lot of fibrosis within the bone marrow as well. And then you get the whole range of plasma cell dyscrasias. And then we're not getting the signal here for any lymphoma or leukemias here. So what does that leave? That leaves peripheral processes. Again, the systemic disorders where you may get pancytopenia. So rheumatoid, lupus, we're not getting that flavor here. So I'm in the domain of marrow infiltration possibly being a cause for this presentation. And somebody at a young age, this is very disconcerting, having such a severe presentation. So definitely needs further workup. Any other thoughts, Ibrahim, while I sort of rummage through possible causes? Any ideas that popped up into your mind?
Yeah, so actually, the teardrop cells are truly interesting for me. But I wonder why this patient is not presenting with splenomegaly if there is extramedullary hematopoiesis. And then also, I think I really like the point where you brought up the myelofibrosis as bone marrow infiltration. And I think also for this patient who is presenting systemically, right? So they have this mouth ulcer, and then they also have the photophobia and the fatigue. I think cancer should be also on the top of the differential. And specifically to the bone marrow, I like to think of things like hemophagocytic lymphohistiocytosis. But then this usually would present with destruction of RBCs. That would actually contribute to the anemia and the pancytopenia in general due to the bone marrow infiltration as well. But then I can see that the bilirubin, in this case, I think it was not elevated. So I think that's interesting. But malignancy and myelofibrosis in general, I think that should be on the differential as well.
Okay, so a lot of possibilities. Amanda, help us, give us some more data to help us along the course.
So the calcium is 9.7. total bili 0.9, protein 8.3, alkaline phosphatase 77, AST 15, ALT 16, per time 13 seconds, and ENR 1.2. We did an ultrasound normal and an abdominal CT normal too. And what you said, Ibrahim, when we saw these labs, the first thing that my professor told us was go and see the patient again, like his abdominal again, think like trying to find hepatosplenomegaly, like you said, but doesn't have.
So Ravi, would you like to take it on from here?
Sure. So not much here. This data does help us sort of weed out a couple of things we had thought about. So I really like the point you had mentioned about extramedullary hematopoiesis. So there's no shift to other centers for blood cell production, like the liver and spleen, like you had mentioned. The LDH is the only red thing I see here. There's no coagulopathy here as well. So nothing to signal that there may be something in the hepatic system, or is there something ominous like a hemolytic process like DIC where you will get coagulopathy? So we're kind of coming back. I'm going to have to sort of tear up the script and sort of tread back to the CBC again. And I'm trying to think while Amanda was going through this next bit of data, what could cause macrocytic disease, like you had mentioned again. So there's no signal for liver disease. Alcoholism could cause that. Hypothyroidism could be a cause as well. But again, here hypothyroidism would cause anemia, but not pancytopenia to this degree. Medications, again, the acetaminophen, I doubt would be. There be a number of medications which could cause macrocytic anemia. And then the bone marrow disorders we talked about, like myelodysplastic syndromes, multiple myeloma, aplastic anemia. And we talked about, we didn't talk about pure RBC aplasia, but here we have obviously a pancytopenia. I don't think PNH would cause it to this degree. There'll be other associated signs and symptoms. And again, there will be a hemolytic process of play. So yeah, I'm sort of wading in the dark here. I have a couple of thoughts here, but it's kind of early to commit to a diagnosis. But any other thoughts, Ibrahim, before we move on?
Yeah, so I think a lot of people actually bringing up some great thoughts within the chat, specifically regarding the dark urine for hemolysis. But I think at this point, we've probably established that this is not a peripheral problem. And then some people are also mentioning the TSH and the T4. And you also brought up that for the macrocytic anemia. But then again, this is a pancytopenic presentation. So I think that's interesting. But then I think people are also bringing up the fact that they might be presenting with an autoimmune disease. So I wonder, Amanda, is there some kind of ANA, some kind of antibody panel, as well as for bone marrow biopsy?
Yes, so we have some tests like HIV, hepatitis B, C, and parvovirus, all negative. And we have the bone marrow biopsy that gives us the diagnosis. Can I read?
What do you think, Ibrahim, at this point? So yeah, we had to go through the conventional testing, HIV, hepatitis, and so on. So now, any thoughts of a diagnosis before we? I think the bone marrow biopsy is going to be key.
Right. So I'm honestly at this point, I'm thinking malignancy, myelofibrosis, myelodysplastic syndrome in particular, but then meds as well. I don't know, would you like to further on that diagnosis?
Yeah, I think those are in the running. I really do like the myelodysplasia as a possible cause, especially with this teardrop. I think it may be one of my biases, but there are several types. I know the -5q, you get this Polgar-Hewitt cell, which is of the -5q variety, which carries a good prognosis. I'm going to see if that's in the bone marrow. That'll be very exciting. We'll see if Amanda can give us the biopsy. So let's go.
So the bone marrow biopsy showed markedly hypocellular marrow for age, implicating aplastic anemia, and there was no increase in blasts or plasma cells, and no lymphoid aggregators or granulomas. Oh my God, so hard to read this in English. I will send in the chat here.
Interesting now.
Very interesting.
Yeah. Any ideas, Ibrahim, before I kind of jump in?
Yeah, so I think the diagnosis of aplastic anemia is interesting, but I also think that there was probably some kind of underlying cause to that aplastic anemia. So I'm trying to think, since this patient had presented with these symptoms right after they received their amoxicillin, could that be the underlying cause to what they're presenting with? Could it be some kind of side effect? And then I'm thinking as well, in the future, would this patient resolve this aplastic anemia, or would it chronically persist with them? But I'd love to hear more about you.
Yeah, I think linking it back, we kind of paused there and looked over the drugs. And I'm sure somebody had also mentioned a great point in the chat. Can a beta-lactam cause bone marrow suppression? Why not? It could be. I don't know the mechanism. It could be molecular mimicry, direct toxic effect on the bone marrow. And with this bone marrow biopsy showing marks hypocellular and then aplastic anemia, we have to go through the framework for aplastic anemia. And I think you did give us a parvovirus B19, another thing that we commonly teach. And then beyond that, we have to start thinking about toxic effects and what can happen with the bone marrow and aplastic anemia. That also brought back up, just want to mention PNH as a cause of aplastic anemia as well. And MDS usually will have a hypercellular bone marrow. In this case, we have a hypocellular. So in this case, I'm kind of interested. You also want to emphasize the HIV and hepatitis in thinking about aplastic anemia as well. But the amoxicillin definitely is very interesting. I don't know how to test for that, or is it just simply withdrawing it and then you see a resolution in the bone marrow findings? But I'll send it back to Amanda to see what else did she find.
So, like this diagnosis is what about exclusion, diagnosis of exclusion, because we did all the serologies, all the things we imagine we did, and the team of M-Onc concludes that the patient has aplastic anemia, maybe due to his recent use of amoxicillin. So it's more exclusion and associated with amoxicillin and immunosuppression. And the other cause more common, like viral infections, like bacterial infections, idiopathic, it was excluded.
Fascinating. So it was worth our while to take a stop at the meds and sort of start thinking through it. But I think at that juncture, I had no idea what was going to unfold in front of us and how it would relate. We talked about associated liver toxicity, DILI, maybe systemic issues like drug-induced hypersensitivity syndrome. But I couldn't really fathom that this was going to fold or develop into severe anemia or pancytopenia and these findings. But something else to put on my reading list of amoxicillin-associated bone marrow suppression. So great case, really did tie my brain into knots, and just reflecting on this, it's a great case. There's so many. I think for me, there was a lot of sort of presenting complaints here: headache, dizziness, and weakness. And I really like that Ibrahim talked about the dizziness and possibility of it being a volume issue, namely anemia, and not dehydration. And we didn't have orthostatics, but that would be helpful. But then this wide pulse pressure and then the pale skin. Did this small lingual ulcer, was that associated with the abscess, the dental abscess, I guess? Is that on the same side as the dental abscess? It was. So it sort of maybe a detractor, but that was kind of interesting to stop there at that juncture and sort of explore that and try and connect it to the problem, the larger problem here. Any reflections, Ibrahim?
Yeah, so I think I'm also thinking about yesterday's case, where we also had an adverse drug reaction to a medication. And I really like the point that Dr. Berger brought up, that it's fine sometimes to call it idiopathic, not necessarily drug-induced, but then you don't want for the patient to develop pancytopenia in the future if they had another dental abscess. For the time being, I think if this were me, I'd probably return back to the literature, see if there were other cases, reported of amoxicillin-induced aplastic anemia. If not, I'd probably just call it idiopathic.
Yeah, and I think Amanda gave us sort of the causes of aplastic anemia, sort of a run through. So we do know the viruses, toxins, ionizing radiation, nutritional deficiencies, and the infections as well, which was mentioned.
Right.
So thank you, Amanda. Great case. Really appreciate you presenting it. Very informative. Great journey through the river of blood. So I always think about Ravi's river of blood to think I'm a little cell moving through this whole amazing microcosm that helps to run the human body. So Noah is going to do the teaching points. We'll have Noah take us home.
Hello, everyone. So today we began dissecting the initial presenting symptoms. So we talked about dizziness. Firstly, we have to define what the patient feels. Maybe it's not vertigo, maybe it's just lightheadedness, which was in this case. Also ask additional symptoms and perform a focused exam. For instance, hints for central causes of vertigo. Then we talked about headache, the red flags, these pneumonic, so systemic symptoms, neurological symptoms, the onset, older age, or other associated features that may warrant a more intense investigation. Tying it all back to the case, it's a younger patient. We didn't have many localizing symptoms. We talked about the recent history of infection, which would increase the possibility of infectious complication, but we needed more signals. On physical exam, relevant findings were the lingual ulcer, the pale skin, the low diastolic blood pressure, all very non-specific, but it all gave signs to a more systemic disease. After we looked at the labs, we talked about the approach to pancytopenia. The schema on the Clinical Problem Solvers website, it suggests 3 pathways. So bone marrow infiltration, bone marrow failure, or peripheral process. Infiltration can be either from malignant or non-malignant processes. The bone marrow failure couldn't be nutritional causes, suppression, or immune destruction. And peripheral processes can be autoimmune diseases or tick-borne infections, and so on. The teardrop cells they were the only clue of a possible diagnosis, maybe infiltration. That's why we focused on maybe bone marrow fibrosis. More labs didn't give us any additional signals. Then we went back and looked over the causes of macrocytic anemia. They can be megaloblastic, B12, B9 deficiency, copper deficiency, alcohol, liver disease, hemolysis, MDS, and so on. But again, no strong signals for any specific disease. After the bone marrow biopsy, I dived into a little bit more in the bone marrow failure. So we have the nutritional, the suppression, and immune destruction, which we talked about. Aplastic anemia was the final diagnosis. And one sentence, which I think can summarize our cognitive processes during this VMR, is no signals, don't force the diagnosis. We kept our minds open and we didn't try to fit this illness into illness script without the additional symptoms.
Wow, incredible, Noah. Very organized, pragmatically delivered teaching points there. It's almost like I was listening to a lecture there. So expertly done. I'm just so in awe. Thank you. Actually, going through that, I was sort of highlighting some of the points in my thinking, and definitely very helpful. You caught all the pertinent points that helped us in getting to the diagnosis. Thank you, Ibrahim. I just asked Ibrahim to help with the discussion, but I'm also knocked out by your discussion and how you grasped at some points, and it helped me actually to highlight or shine the spotlight on some of the issues that were leading to the diagnosis there. So I really appreciate you helping out today. And Amanda, another great case there. So thank you very much. I know it's not easy to then just present a case on the spot. So take care, everybody. Have a great rest of the Tuesday, and see you back tomorrow. Take care. Bye.